Welcome everybody to the Point of Care Foundation's inaugural webinar, Leadership in Compassionate Healthcare, presented by Jocelyn Cornwell. I'm Debbie Sandford, Chief Operating Officer of the Point of Care Foundation and Director of the Schwartz Rounds programme here in the UK. I shall be your chair today. Before we begin, I'd like to go over a few details relating to our agenda. We've allowed an hour for today's programme, of which approximately 40 minutes will be presentation, with the remainder at the end for a question and answer session. The webinar is being recorded and it will be available on the Point of Care Foundation's website, www.pointofcarefoundation.org.uk, in future. Please note that you're participating in listening only mode, but you can interact with Jocelyn and me via the chat pane, which should appear at the bottom left of your screen. Please do use this function. If you have a question, just type it into the chat pane area and send it to us. We'll try to answer as many of your questions as possible at the end of the session. In fact, please could you let us know now via the chat window that you can hear me? Excellent. Feedback's coming in, but you can hear me. I'm very pleased about that. Unfortunately, our ability to help you during the webinar with any technical issues is very limited, but we would suggest that you should, if these happen, you should start with logging out and logging back in again, because there might be a problem with connectivity. We'll also be polling the audience during the webinar, and we hope that you'll participate in this. And finally, before exiting, you'll receive a very short electronic survey that we ask you to complete in order to get your feedback on the session. It's really important to us and will shape what we do in future, so please do take the time to do this. This webinar is brought to you by the Point of Care Foundation, an independent charity that works to improve patients' experiences of care and increase support for the staff who work with them. Our vision is a radical improvement in the way we care and are cared for. We believe a truly patient-centred approach, listening, understanding and responding to the needs of the whole individual, is essential to the delivery of the best possible quality of care. Our first and still best known achievement is to have successfully brought Schwartz Rounds to the UK, and I'm really delighted that our first webinar is being broadcast to members of our Schwartz community. And now it's my pleasure to introduce Jocelyn Cornwell, today's speaker. Jocelyn's entire career has been in healthcare, as an academic, a manager in NHS community services and a regulator. She's a visiting professor at Imperial College London and a trustee of the Nuffield Trust. She's also the chief executive and founder of the Point of Care Foundation. Jocelyn.
Hello everyone, it's absolutely thrilling to talk to you all, and thank you all for saying hello in the chat panels. I can see that a couple of you have got connectivity problems, which I suspect are local, but Bex and Esther are doing what they can at our end to make sure that things get better if there's anything we can do. I just wanted to echo what Debbie was saying, which is that it seemed right to make compassion in care our focus for our first webinar for the Schwartz community for a number of reasons. It's appropriate because the Schwartz Centre's name, after all, is the Schwartz Centre for Compassionate Care, and our own mission, like theirs, is to strengthen relationships between caregivers and patients. But also because there have been a range of concerns in this country, as well as in other healthcare systems, about the human aspects of healthcare in organisations that are both large and small. And there's a particular concern about the human aspects of healthcare at times when health services are under tremendous financial pressure, as they are now. Let's go to the learning objectives. The learning objectives for this session are as shown. Compassion in care is a big topic, and I can't attempt to cover all of it in depth today. But by the end of the session, we will have defined compassion and related concepts. We will have discussed why it matters to patients. We will have touched on some of the big controversies without going into any of them in any detail. We'll have identified factors at different levels in organisations that can undermine compassion and care. And then we'll end by examining the actions that leaders can take to strengthen compassion and care, again, at multiple levels. The slide walks you through the topics that the session will cover that are going to be related to those learning objectives, and I'll just give you a minute to read through them. Okay, so let's start with a poll. From time to time through the next part of the session when I'm talking, I'm going to ask you to participate in polls. In every case, there's no right answer, but what I suspect is that there may be different opinion, and I'd like to find out what you think. There are going to be 5 polls in total, and this is number 1. What is compassion? Okay, I'm going to give you 15 seconds to answer the question. Just give you a bit longer, and I'm going to speak up because I gather some people can't hear me. So let me know whether this is loud enough. Just waiting for some more people to vote. Okay, I'm going to stop the voting there, and I'm going to share the results with you. And I think that you can see, I hope that you can see that 74% of you who've voted says it's an attribute of the individual, 44% think it's an attribute of the team, and half of you, 55%, think an attribute of the organisation. And it's great to see a range of responses, actually, because that gives me a jolly good basis for carrying on. So let's go to the definitions of compassion in the literature, starting with the one at the top, which is Jerome Lowenstein's definition. Jerome Lowenstein is a nephrologist, a writer, and founder of the humanistic aspects of medicine education seminar program at New York University School of Medicine. He's the author of a collection of wonderful essays called The Midnight Meal and Other Stories, which is worth looking out for. And you can read Lowenstein's definition there. He talks about compassion as being empathy, respect, a recognition of the uniqueness of another individual, and the willingness to enter into a relationship in which not only the knowledge, but the intuitions, strengths, and emotions of both the patient and the physician can be fully engaged. Chochinov, below, in 2007, he's a psychiatrist and works in palliative care medicine in Manitoba. He was writing in the BMJ, and he describes compassion more simply as a deep awareness of the suffering of another, coupled with the wish to relieve it. And please bear these 2 definitions in mind as we go on through the session. Lowenstein's contribution is he draws attention to the 2-way nature of the relationship the engagement of the caregiver's own feelings and own self in the relationship. And Chochinov more straightforwardly simply states two elements that are involved: a deep awareness of the suffering of another, coupled with a wish, the desire to relieve it. I think it's worth thinking just for a moment about the difference between and similarities between compassion and the related concepts of sympathy and empathy. In the dictionary, the synonyms for sympathy are feelings of pity and sorrow and understanding of another's feelings. It's one-way traffic from one person to the other, and it's without action. Empathy is synonymous with compassion in most definitions, and it does include the action to relieve suffering. It differs perhaps in emphasis with compassion on the extent to which the feeling for the other involves something of the person who feels the compassion. But I think it's a pretty moot point. But if you look in the dictionary definitions of these two words, empathy and compassion, I think what you'll see is that empathy is more secular in its associations. So you see words such as affinity, appreciation, and being on the same wavelength associated with empathy, whereas the synonyms for compassion have words which are more religious or spiritual in origin, words like grace, mercy, and clemency. I think it's useful to stand back for a moment, though, and to look through a wider lens at patients' experience of care in the round and to understand the part that compassion plays in it. There are a small number of useful definitions of patients' experience which are grounded in high-quality research with patients and families. Going back to the original research in the USA, which was done in the 1980s by Thomas Del Banco and others at Harvard. They wrote a book called Through the Patient's Eyes, which really opened up this whole area of the study of patients' experience. And there's a pretty straight line through from Del Banco's work to the founding of the Picker Institute in the United States, which was responsible for developing the first national patient surveys, and then through again to the Institute of Medicine and to their seminal work on quality and quality improvement, which was Crossing the Quality Chasm, published in 2001. This framework that you see in front of you, the set of definitions here, is also adopted in this country by the National Quality Board. And the important point I think to make is that, and all the frameworks and definitions make this point, that patients' experience is multi-dimensional. So the third bullet there, emotional support, empathy and compassion, is one important dimension, but there are others that are also important. And if we move on, it's often difficult to remember, I think, these fairly long lists of bullet points, but it's useful to think, I think, in terms of two dimensions that make up the totality of patients' experience. One is what happens to patients, the transactional, and the second is the how the care is given, the relational aspects. And if you look down the bullet points, I've annotated them as to whether they are purely relational, as in the first one, respect for values, preferences, and expressed needs, and indeed the emotional support, empathy and compassion one, or whether they involve transactional elements as well, so that you can see that something like transitions and continuity involve a good deal of what is happening to the patient, how are they being transferred, what is the delay, if you like, for discharge from hospital, when is the outpatient appointment, those kinds of things. Those are all the transactional elements, but they're coupled with the relational aspects, the communication, the information, and so on. So the important part, I think, is that the frameworks are useful, but here I come to another slide, which is from an article in the BMJ. And the picture you see there is of Kieran Sweeney. Kieran was a GP, he was a professor of primary care in Exeter, and he was diagnosed with mesothelioma, asbestos-related cancer, when he was 58. This was Kieran writing about his experience for a paper in the BMJ. Kieran died a year after he was diagnosed, and during the period that he was still alive, he put as much time and energy as he could into sharing his reflections on the human aspects of medicine with his colleagues, and particularly with medical students. You can see a film of Kieran talking about some of his experience on our website. In the BMJ paper, as you can see here, Kieran uses that distinction between the transactional and the technical aspects of care, the scans, the tests, the appointments, all of which were well managed and timely. But he also says that the relational aspects were poor at times, and that they confirmed his worst fears, he says, of losing control, not being able to say, this is who I am. And this is a reminder, I think, of Lowenstein's definition about compassion being a recognition of the uniqueness of the individual. The critical importance of respect for the patient's autonomy and the willingness and ability to act out of that recognition is a strong theme in the discussion about patients' experience and in medical humanities. And this slide shows Atul Gawande next to a quote from his new book, Being Mortal, which is a brilliantly written argument for strengthening the human side of medicine. The more you think about what Kieran and Gawande are saying about all of our feelings, about our own autonomy and the threat that illness poses, the threat that being looked after and having to depend on other people poses, the more clearly I think we can see that compassion, the willingness and ability to engage with the patient enough to understand what he or she is going through, and the willingness and ability to act out of that awareness is so fundamental that it trumps the other dimensions of patients' experience. And this slide quotes Ken Schwartz. Once again, note the importance of the relational aspects of care, the value to the patient of the moments when he's made to feel like a human being. I think it's worth reading Ken Schwartz's paper in full. I quote it here because he goes on to talk about what it is that caregivers do that makes people feel human. He talks about the small acts of human kindness, the touch of a hand, a look, a smile, a caregiver remembering something about him as a person, that he's a father, a husband, or remembering his name correctly and using it. And the small things is a recurrent theme in patients' and carers' accounts of experience. And those small things rarely, if ever, involve caregivers spending more time with patients than they do already. But they do ask caregivers to engage, to bring something of themselves, respect, warmth, kindness, humanity, into the interactions with patients. In the NHS Constitution, there's a section on compassion. And again, even here, you see that this idea of the small things is repeated. And also the idea of caregivers giving something of themselves to patients. We respond with humanity and kindness to each person's pain, distress, anxiety, or need. We search for the things we can do, however small, to give comfort and relieve suffering. But combining the transactional and the relational aspects of care is a big challenge. we might well ask, why do we need to talk about compassion and care if what we're talking about is apparently small acts of human kindness, a smile, a look, as Ken Schwartz said. The matrix shows in an abstract way the theoretical relationships that are possible between the transactional and the relational aspects of care in any particular place, in a unit, a GP practice, a clinic, a ward, an intensive care unit. In any of these settings, it's perfectly possible for the service to perform better on one dimension, on the transactional, than on both, than on the relational, say. If you take a minute to think about your own unit or department and ask yourself, how well does it perform? Does it perform really well on both being efficient and people being kind, warm, and so on? I think you can see that it's a huge challenge. It can be very difficult to combine very good transactional process with warmth and human qualities. And so for the next few minutes, I'm going to ask you to participate in some quick fire polls about some of the big debates and controversies about compassion and care. First up, health professionals are more caring than other people. True or false? Okay, let's see how you vote. Okay, we've got a few more answers coming in. I'll just give it a few more seconds. Brilliant, you're all voting. Thank you. You seem to be... Okay, I'm going to end the voting here, and I'm going to share the results with you. And you can see that you're equally divided between whether health professionals are more caring than other people. 44% of you think yes, it's true, health professionals are more caring. 47% think no, it's false. Okay, so poll number 2. Sorry, poll number 3. You can teach compassion, true or false? Okay, I'm going to end the voting now and share the results. And you can see that the vast majority of you, 76%, think that compassion can be taught. But some of you think that it can't. 17% of these very small numbers, 34%, 34 people in total, say compassion cannot be taught. Okay? And now we'll go to the next poll. Staff who are unkind to patients are bad people. True or false? Okay, I'm going to end the voting here and share the results. And as you can see, again, the vast majority of you are in agreement here. Perhaps one or two of you think that staff who are unkind to patients are bad people, but the majority of the people who've answered the poll say that's a false statement. They're not bad people. So just to reflect on the results of those polls for a second, I think that most of you, no, I think you were equally divided on whether health professionals were more or less caring than other people. And I think that's a question which is interesting in relation to the question about whether people have a vocation anymore to go into the professions. And it seems that probably about 50% of you think that healthcare is still a vocation, whereas perhaps the others don't. Then there's the question of, can you teach compassion? And most of you say you can. What does that say then, if you think that it can be taught, about the importance of recruiting and selecting for compassion? Does that mean that that's not an important thing to do? Or does it mean that you can select anybody and that then you can teach them? I think that's the kind of question we should be asking. And then the third poll that I put to you, staff who are unkind are bad people. Now, if that were to be true, I think we could say that the tabloids were right in the way that they treat all of the problems in health and in social care when they emerge into the public light. If it's false, if it's wrong, as most of you say it's wrong, then how do we explain the actions of the staff who are unkind to patients when they're unkind? And let's assume, as you have done, that for the moment that it is false, that it's possible for good people to deliver bad care, and consider for the rest of, for the next sequence in this webinar, what are the factors that might undermine compassion in care? And I want to think about these factors at three levels: the individual, the team, and the organisation. And I want to start with the first, which is the individual, and there are 2 points here. First is with the one that I think of as the existential problem, and again, this is the picture of Kieran writing about his experience. And I'll give you a moment to read the quote. So Kieran's making the point that the perspectives of patients and of staff are profoundly different. And the relevance of this process of normalization, which happens to staff, whether they like it or not, is that it makes it harder, when the work is routine and familiar, for the imaginative work involved in compassion to occur. And here's the second point about individuals. Psychologists tell us that empathy is normally distributed in the population. At one end of the spectrum, you have people with zero empathy. These are people with certain kinds of autism, mental illness, and personality disorder. At the other end of the spectrum, you have the super empathizers. Both these groups are minorities, and most of us are distributed somewhere across the spectrum in the middle. But everyone, even the super empathizers, has the capacity to switch empathy off and to be in what psychologists call I mode. And they're more likely to do so under certain conditions. When they're very tired, when they're stressed or burned out, when they're under pressure to do something else, interacting with a patient who's unpopular for whatever reason, drunk, aggressive, when they're very emotional, afraid, angry, frustrated, or distressed, or when they're working with digital equipment. All of these conditions prevail in healthcare environments almost all of the time. The next level up is the team, and we now know from research that the team that the individual belongs to is an important determinant of the relational aspects of patients' experience. This is a reference to recent research by Jill Mabon and others, which is very important. Mabon's research tells us that staff experience shapes patients' experience, not the other way around. We've known for some time about this association between staff and patient experience, but Mabon's research goes deeper and demonstrates that there is a causal mechanism involved. Staff well-being is an antecedent, they say, not a consequence of patient care. And there are a number of factors in team working that can undermine compassion in care. Poor communication, people not being clear about their own roles or the roles of other people, team members not knowing one another by name or being used to working together, conflict within the team or between one team and another, lack of leadership within the team, and staffing levels that are insufficient to cope with the level of activity. And then the third level is the organisational level. Oh, we've lost a slide, I'm sorry. Sorry, I'm a bit phased. I had a lovely picture in there of Robert Francis, which was just to draw your attention to the range of reports that we've had recently from organisations that have been subject to inquiry. Mid Staffordshire, Winterbourne View, Morecambe Bay most recently. And in all of these reports, they make the point that organisational culture is important. And organisational factors that can undermine compassion are these: bullying, target-driven priorities, disengagement between managers and staff and managers not meeting and not speaking together, low staff morale, isolation. Isolation is geographical isolation of organisations, as in the case of Morecambe Bay, or professional isolation, a lack of contact, toing and froing between the organisation and the outside healthcare community, as was the case in Mid Staffordshire. And then there are these cultural things, a lack of candour in the way that people talk to patients, an acceptance of poor behaviour between colleagues, a reliance on external assessments inside the organisation, so that people, as it were, abdicate responsibility for deciding on the quality of care for themselves and just wait for the regulators to come and talk to them about it. And denial, refusal to accept that care is poor when it's pointed out to them by patients or in complaints. So what is the role of the individual leader in all of this? What can leaders do at all the various levels of the organisation to enable compassion in care? So let's go to the level of the individual. At the level of the individual, there's a number of things that individuals can do to enable compassion in care, actions that they can take alone, practicing mindfulness, seeking opportunities for reflection and reflective practice, looking for opportunities to find out about the personal details about patients. And there are things that they can do with their colleagues together, horizontally, providing good role models for newcomers and junior staff, being mutually supportive in the way that they work together, paying attention to themselves and others, reminding themselves and others about the importance of thinking of patients as people and about the impact on patients of the relational aspects of care. Then there's the level of the team and the responsibility of the leaders at the team level. And this level is critical, going back to Mayburn's research. And there are important actions that team leaders, frontline supervisors, team leaders, middle managers can take that will enable compassion. There's ensuring that staff numbers, skill mix, and their activity are in balance, and giving staff, allowing staff to have control over their own sphere of work, so that if there are actions that they can take, the small actions that they can take to respond to patients, then they can make them. There's creating time and space for reflection, as in Schwartz rounds, and creating physical space for staff to meet together away from patients. I've been on wards where staff meeting rooms have been full of furniture, full of equipment, and they're just not used spaces in which staff can meet and refresh themselves away from patients. Make sure that staff take rest breaks and refresh themselves. Use patient feedback as much as possible, and use stories about patients in staff meetings. And then at the level of the organisation, the leadership is immensely important. The engagement, which is a two-way process between employers and employees, which involves welcoming and encouraging feedback and ideas from staff, from patients, and from carers. There's the communications work of articulating what good care means so that everyone understands it, and expressing it in plain language, not in boardroom words such as patient-centered care. There's the behaviours. There's refusing to tolerate rude and unkind acts, whether they're towards patients or towards other colleagues, and challenging language that objectifies patients, challenging language that talks about patients as bed blockers, that talks about patients as breaches, talks about patients in terms of their diagnoses rather than as people. Is listening to stories from patients and carers and creating the processes for doing that, and listening to the stories of staff. And in the best organisations, what you see is the most senior people from time to time work alongside staff on the front line. And we're going to go now to our final poll, which is that I'm going to ask you to choose one thing that you could do if you were, as I'm sure many of you are, leaders. What you can only do one thing to strengthen compassion. What will it be? And I'm afraid I've given you a somewhat limited list to choose from. So there are 5 things you can choose from in this list. You can make compassionate values the basis for recruitment. You can monitor staff stress. Make training in team building mandatory for first-line supervisors and managers. Make compassion in care a corporate value and objectives. Or you can establish a patient and family advisory council to give feedback to the board. Where will you put your vote? Okay, I'm going to give just a couple more seconds for the results to come through. And I'll end voting there and share the results. Okay, I think the results are fascinating because, as you can see, there's a lot of difference of opinion about where you would put your money. I think the majority of you, where there's a sort of any larger number of you, you've voted for making compassion and care a corporate value and objective. A third of you have gone for that one. And then The next most popular is monitoring staff stress, although as one of you has pointed out, Rory, no point monitoring staff stress if nothing's done with the results. And then you've got, and then there's kind of roughly 10% make compassionate values the basis for recruitment. Training in team building mandatory for supervisors and managers. And I'm pleased to see that some of you have voted for establishing a patient and family advisory council too. But I think the point that comes across from this is that actually it's not one thing, it's going to be a bundle of things, a set of things that organisations need to do at different levels in order to enable compassion in care. My choice for what it's worth is that I would have gone with the majority of you. I would have named compassion as a corporate value. So let's go to this, which is just pretty much where I want to end, which is noting that it's useful to remind ourselves that the NHS Constitution recognises the importance that staff experience is important, and that we cannot take for granted that staff are going to be compassionate, and it doesn't assume that it's built in to professionals. It acknowledges the importance of tools, training and support to deliver compassionate care, and this is something I think is always worth reminding your organisations about, that it's in the Constitution. And so just to summarise and to remind you of the learning objectives, we wanted to define compassion in care, which we started doing by looking at Lowenstein and Chochinov. We wanted to understand why compassion in care matters, and I hope that I will have convinced you that it's one dimension of patients' experience, but it's probably the one that trumps all others. We considered some of the controversies in those polls in the middle of the session. And then in the last two sections, we've looked at the factors that undermine compassion in care at the level of the individual, team and organisation. And then at the set of things that leaders, particularly in team and organisational roles, can play in enabling compassion in care. So I will stop there and hand back to Debbie to moderate the questions.
Thank you very much, Jocelyn. Thank you for a very interesting presentation, and there's been a fascinating discussion going on in the chat pane here as well, which I'm sure most people have been following. We've had a lot of chat. I've been trying to turn them into questions, I hope with some success, but if anybody would like to just rephrase anything that I'm not asking as a question in the chat pane, that would be very helpful. I think in line with your presentation, Jocelyn, we started off talking about the individual, and so the early discussion was about the individual. And one of the questions that came through strongly for me there was can you actually teach compassion? And people felt mixed about whether some people were more predisposed towards compassion than not. And I suppose the first question for you then is, do you believe that compassion can be taught?
Actually, in Lowenstein's essays, he talks about a session with students where he asked the students, can compassion be taught? And the answer from one student came, I don't know, but I know you can teach the opposite. And I think that pretty much states my view on this, which is, I think that it's highly possible that there are people at one end of that normal distribution of the population. There are probably some individuals who it would be extremely hard to teach compassion to, but that for most people who are somewhere along the normal distribution, it can probably be taught, but more importantly, it can be sustained, reminded, enabled by having a good environment around, wrapped around the staff who are delivering care. And we don't know, actually, as far as I can tell from the literature, definitively whether it can be taught. We know some things about the elements that are important, including the importance of role models in influencing other people's behaviours. But so I think I think the answer to that, from my point of view, is equivocal, and that probably I would put more weight on the factors in the environment that help to mould and shape behaviour, other than just training.
Well, that leads on to the second question, which is, how do you measure intrinsic compassion?
Well, this is a question for psychologists more than it is a question for me, but I mean, these are done through psychological questionnaires and psychometrics. Yeah. Usually sets of questions about how you would respond in certain situations and your answers on those things.
And do you think that patients can detect feigned compassion?
I think for most patients, even feigned compassion would be a nice thing. You know, a smile, even if you don't feel like smiling. If you listen to what patients say about outpatient appointments and about what it feels like when you arrive in an outpatient clinic and you're greeted with at worst a snarl. And how miserable that can make you feel when you're already anxious. I think even feigned, not compassion, but warmth and friendliness is immensely helpful. Yes.
And does compassion require people to be brave?
Yes, I think it does actually, and I think that's because it does actually if it's not feigned, it does, as Lowenstein says, asks you to give of yourself. And I think it requires bravery and stamina and resilience. And one of the things, if you look back at Kieran's quote and at his article in the BMJ, he chastises people for a lack of courage in talking to him. He felt that his colleagues who knew him, after all, that was his difficulty, was that he was being looked after by people who he had worked with. And he chastised them for a lack of courage in facing up to telling him his own diagnosis, because they were wanting to protect themselves from the pain of talking to him about it rather than thinking of him. Yeah.
What about the relationship between compassion and hope? Was mentioned in the chat pane much earlier on.
I think that's an interesting question. I think that if you think about the definition of compassion, which is the recognition of another's suffering and the wish to relieve it, most people who've had experience as patients and who write about their experience talk about how important hope is, hope and optimism. And Ken Schwartz is actually very strong on this himself, and on the importance, even when your situation is hopeless, which Kieran too wrote about, how important it is for people to give you hope that the process that you're going through will be endurable, for example, so that there are always things that people can find to be hopeful about, even in situations that seem hopeless. And for most people who are suffering, that's a very important thing to feel. So I think it is bonded to compassion.
There was also quite a lot of discussion moving on a little bit further from the individual to the organisation. There was quite a lot of discussion about how to be compassionate in an environment where resources are very limited, people, time, the general rush that everybody operates in. Could you comment on that, please?
I think it's just very important, which is why it's one of the things that if you look back at the slides later, in the team factors that undermine compassion, it's an imbalance between staffing levels, the resources and the activity. And I think the reason for that is that when people are under stress, it's much harder for them to feel compassion. It's much harder for them to do the imaginative work of empathizing with another. So the reason that the lack of time and the pressure is so important is because it increases the difficulty for individuals of overcoming their own stress and distraction. So I think it's important, but I think it can also be overstated because of this point about the small things, the small acts of human kindness. And the interactions with patients are happening all of the time. The point is how to think about it, how to think about turning even short interactions into ones that can be kind and positive on the relational front rather than brusque and impersonal.
Well, talking about the small things, there was also quite a lot of debate thrown up by the last poll where people were only able to pick one factor, one thing that they would say to do. And I read the tension as being between a top-down approach and a bottom-up approach. And people seem to be saying you need to do both, which is obviously very hard when you're only allowed to pick one answer. But people clearly felt that that sometimes somebody wrote that organisational bullying can start at the top, and sometimes it can just permeate down, or there can be a value that's stated at the top that is simply used to beat staff up and not really used to promote compassion at all. And that other people wrote how actually thinking that the small things can make a big difference is very uplifting in a way, because we can all do those small things. Would you care to reflect on that tension between top down and bottom up?
Well, I deliberately created that poll so that we'd all be forced to identify with senior people, actually, and with the difficulty of knowing, as it were, there's a limited range of things that most people in most roles in most organizations can do at any one time. And it was just to force us to think as hard as we could about what would be the point where you would get the most leverage on this. And of course, it needs both top-down and bottom-up action. I mean, it's absolutely true that all cultural change requires action at every level, and it requires action over time, sustained action over time. So it's not one thing, it's a set of things. But I think in the NHS, as we have grown used to it, we have grown used to a very top-down system, and one that actually has resulted in very harmful ways of interacting in many organisations. Bullying and harassment, as we know, are far too common. And so I think that it's very important to emphasise the bottom-up and to give energy and put energy and resources and understanding and insight into the things that can be done in a bottom-up way to change culture.
Well, I'm about to ask the last question I have that I've taken from the chat pane, so I thought I would give you some notice. If anybody has any more questions, we might have time for maybe one more afterwards. Do write it in now. But the last question I have is, even going above the level of the organisation, what factors do you think might undermine compassionate care above the level of the organisation? What might be able to be done on a regional or national level that would help promote compassion?
Well, we've been thinking a lot about this actually at the Point of Care Foundation over the last few weeks, because we've been thinking a lot about the election and post-election. What would we want to say to an incoming government? I think that the actions at the top of the NHS are very important, and in NHS England and in the regions. I think it's really important that we see national leaders and professional bodies continuing to pay attention to patients' experience, to compassion, and continuing to say that this is important. There's always a danger it can slip down the agenda, and I think that we should be doing everything that we can to maintain the attention to it.
Thank you. Well, I think we've come to the end of our session. So thank you very much, Jocelyn. Thank you to everybody who's attended. Oh, I can see some comments coming in, but I think they're comments really rather than questions. But thank you everybody for taking the time out of your busy day to join us. I hope you enjoyed the webinar. It is CPD accredited and it will be available on our website. So do please encourage colleagues to watch it. We plan for this to be the first of a series of such events, so please look out for our emails and visit our website to find out more about the work of the Point of Care Foundation. As I mentioned at the beginning, we'd very much appreciate your taking the time to complete the 8-question survey on your screen before you log out. You'll see 4 questions immediately, but if you scroll down, you should see the second 4. We do really value your input to help us shape future events, including any ideas you've got for future webinars, for example. Thank you and goodbye.